A very good morning to all. Today, the topic of my presentation is the Stridulous child. We would be covering the following subtopics: the anatomical considerations, airway physiology, clinical scenarios of noisy breathing, classification of stridor, and evaluation. Coming to anatomic considerations, there are certain critical differences between adult and infant larynx which are imperative to remember for an optimum management of a child with stridor. The size of the infant larynx is 1/3 of the size of the adult larynx. It is funnel shaped as opposed to cylindrical shape of the adult. The laryngeal cartilages are much softer in infants, making them prone to collapse. It is placed higher, that is, at C2 C3 vertebral levels as compared to C3 to C6 vertebral levels in adults. It is important in cases of any emergency procedures like tracheostomy to place the incision higher. Subglottis is the narrowest part of the infant larynx as opposed to the glottis being the narrowest part of the adult larynx. Sensitivity is much greater in infants, making it prone to spasm. Anatomy of the supraglottis. This is a 2-month-old child who presented to us with stridor and was diagnosed as laryngomalacia. We can see the inspiratory stridor, the larynx being funnel shaped. On expiration, the supraglottic structures separate, relieving the obstruction. It consists of multiple soft moving parts which are collapsing into the glottis on inspiration. Anatomy of subglottis. This is a 1-year-old child with subglottic stenosis. Please appreciate the biphasic stridor. Here we can see the subglottic stenosis, with the subglottis being the narrowest portion. There is a complete cricoid ring present in the subglottis which leads to static obstruction, and the sensitive respiratory mucosa makes it uniquely prone to complications of inflammation and trauma. Coming to anatomy of trachea, this is a 2-year-old child who presented with tracheomalacia. We can appreciate the expiratory nature of the stridor. Due to the positive airway pressure during expiration, there occurs tracheal collapse, leading to stridor. Physiology of stridor. The Poiseuille's law states that the flow rate varies inversely with the radius of the tube to the 4th power. Hence, a small decrease in the radius, that is, a circumferential edema of even 1 mm, leads to 16-fold increase in the resistance in the infant and decreases the cross-sectional area by up to 75%. A similar edema in adults will only lead to a 3-fold increase in resistance and decrease the cross-sectional area by 44%. Bernoulli's principle states that as the lumen of the airway narrows, the airflow velocity increases. Increased airflow leads to negative pressure on the walls of the lumen, producing airway collapse. Increased airflow leads to turbulence of airflow, hence producing stridor. Here we can see as the lumen of the airway narrows, the airflow velocity increases. The laminar flow is converted into a turbulent flow which produces stridor. Now, noisy breathing consists of 3 clinical scenarios. The first one being stertor, which occurs due to nasal or pharyngeal airway obstruction, for example in adenoid hypertrophy. Stridor occurs due to upper airway obstruction, namely in cases of laryngomalacia, subglottic stenosis, web, or hemangioma. Wheezing occurs due to lower airway obstruction in cases of asthma, bronchiolitis, pneumonia, or aspiration. Now, stridor is a harsh respiratory sound due to turbulence of airflow through a restricted lumen of the laryngotracheal airway. This is an 8-day-old child who presented to us with stridor. We can see the intercostal and the subcostal retractions occurring along with the stridor. Stertor is a low-pitched inspiratory fluttering and snoring due to nasal or nasopharyngeal obstruction. This is a 5-year-old child with adenoid hypertrophy. Here we can appreciate the stertor during sleep. Wheeze is an expiratory wheezing sound due to turbulent airflow through the constricted smaller airways. This is an 8-year-old child with bronchopneumonia. We can see the tachypnea and the wheeze. Now, causes of stridor can be classified according to their presentation. If they are present since birth, they are termed as congenital causes, namely laryngomalacia, laryngeal web, vocal cord palsy, subglottic stenosis, and others. If they are acquired later, they can be due to trauma, infections, chemical poisoning, or foreign bodies, etc. They can also be classified on the basis of the anatomical subsite. The nasal and the nasopharyngeal causes being pyriform sinus atresia, choanal atresia, supraglottic causes being laryngomalacia, infections like epiglottitis, stenosis or valvular cyst, and others. Glottic causes can be unilateral or bilateral vocal fold palsy, glottic webs, stenosis, intubation trauma, and others. The subglottic causes can be croup, hemangioma, subglottic cysts or stenosis, and others. And the tracheobronchial causes are croup, intubation trauma, tracheal stenosis, or due to any external compression by a neck or a chest mass, or due to foreign body. The evaluation of a stridorous patient requires an initial observation of the patient's respiratory pattern, assessment of the severity of the airway obstruction, and determination of the potential need for urgent or emergent airway intervention. History is vital in clinical evaluation and assessment. Timing of the stridor has to be assessed. We have to ask, when did the symptoms start? Because it helps us in the diagnosis. For example, laryngomalacia develops around the first 2 weeks after birth, whereas hemangioma is present during the after 2 months post birth. The duration of symptoms, whether the stridor is episodic or continuous, any worsening or improvement with change in position, or any history of foreign body ingestion is very important. Severity of the stridor can be assessed by asking for retractions, any history of cyanosis, any history of weight loss or failure to thrive, or any associated feeding difficulty. Any association with sleep or activity. If associated with fever or pain, it points towards infections. Any history of neck mass or any swellings, or association with cough. Medical history in the form of antenatal and perinatal history is very important. Any history of prior surgeries or any intervention is important to make out the etiology of the stridor. Also, neurological or genetical history should be taken. There are certain conditions which worsen with crying, feeding, or straining, namely laryngomalacia, bilateral vocal cord paralysis, subglottic stenosis, and hemangioma. There are certain conditions which worsen during sleep, namely retrognathia with tongue-based prolapse, epiglottic prolapse, or adenotonsillar hypertrophy. Certain conditions worsen with deglutition due to a deficient sphincteric function of the larynx. They are unilateral vocal cord paralysis, discoordinated pharyngolarynx, and tracheoesophageal fistula and clefts. Physical examination. Vitals monitoring with oxygenation levels is very important to assess impending respiratory failure or the need for a non-invasive airway support. Complete head and neck examination should be performed. Anthropometry should be done to assess growth and to diagnose failure to thrive. Syndromic assessment needs to be done because certain syndromes present with stridor. For example, Down syndrome presents with congenital subglottic stenosis. Chard syndrome presents with certain cranial nerve palsies. Hence, complete systemic examination is a must. Mental status should be assessed to see any hypoxic damage. The investigations that we do are awake flexible fiberoptic nasopharyngolaryngoscopy, X-rays of the neck and chest, direct laryngoscopic examination under sedation or general anesthesia in operation theatre, CT scan or MRI. The introduction of drug-induced sleep endoscopy allows the determination of levels of stridor and obstruction that may occur during sleep. This is how we perform the outpatient flexible fiber optic laryngoscopy. The child is positioned in the laps of the parent and the legs and the hands are fixed. The head of the child is also stabilized. We instill 0.05% xylometazoline drops to decongest the nose. Also, lignocaine 4% drops at the dose of 4.5 mg per kg of body weight. And then the endoscopy is performed. It is important to record the endoscopy to plan any surgical management in future. The advantages: it gives us a three-dimensional view along with a dynamic real-time assessment of the glottis and the supraglottis. However, it is difficult to perform in a child with severe stridor, and subglottis and trachea are not sufficiently examined. Thing to remember is that we should always have an intubation cart with an emergency tray in the OPD while performing this scopy. Coming to radiology, MRI or CT scan can assist the practitioner to assess the airway and plan the surgical modality. However, it is difficult to perform in a child with acute stridor. Can be done if the child is stable or is intubated. X-rays are quick, safe and an inexpensive modality. Hence, X-ray neck and chest are done to check the integrity of the airway and to rule out any lower respiratory tract pathology. They are also diagnostic in croup, epiglottitis and foreign bodies. Here you can see an X-ray neck lateral view showing tracheal narrowing. Direct laryngoscopic evaluation gives us a complete assessment. Also, intervention can be performed in the same setting. It is performed using age-appropriate laryngoscopes and endoscopes in an operating room setup in the presence of a pediatric anesthesiologist adept in a collaborative airway management. The anesthetist's ability to keep the child spontaneously breathing without a relaxant and without an endotracheal tube in the airway allows optimal examination of the airway. We use sevoflurane and propofol. The importance of a multidisciplinary team cannot be undermined. A pediatrician is required for the holistic assessment of the child. Pulmonary health is among the most important factors that decides the outcome when treating chronic airway lesions. A cardiologist may be required in cases of aberrant vessels or cyanotic heart disease. There is a well-established association between gastroesophageal reflux or laryngopharyngeal reflux and their impact on the inflammatory and obstructive disorders of the airway. Hence, a gastroenterologist is required. A geneticist is required in cases of syndromic children. Last but not the least, an excellent communication with the anesthesia provider is critical for safe endoscopy and to allow the surgeon sufficient time to acquire information and provide any intervention if required. Thank you.